Hello, my name is Dr. Diwan S. Raja. Today I will discuss about the anatomy of the upper limb. This will be a review for the exam 1. So we'll go through the brachial plexus. One of the important nerve of the brachial plexus is the median nerve. Root values of the median nerve is coming out from the C5, C6, C7, C8 and T1 ventral rami of the spinal nerve. So it is getting contribution from all these roots 5, 6, 7, 8, and T1. C5, C6, C7, C8, and T1. Muscles innervated by the median nerve. The median nerve does not supply any muscle in the arm. It supplies muscles on the forearm, particularly the flexor muscles, like that of the pronator teres, flexor carpi radialis, palmaris longus, flexor digitorum superficialis. It also supplies the deep muscle via the anterior interosseous nerve, like the flexor digitorum profundus, flexor pollicis longus, and the pronator quadratus. Flexor digitorum profundus is also getting innervation from the ulnar nerve for the medial part of the flexor digitorum profundus. We will get also ulnar nerve innervation. Lateral side, we are getting innervation from the deep branch of the median nerve, that is the anterior interosseous nerve. Cutaneous innervation of the median nerve will give emphasize cutaneous innervation on the palm of the hand. So lateral 2/3, one finger, thumb, index finger, middle finger, and half of the ring finger, skin, and the palm area is getting sensory innervation from the median nerve. Median nerve also pick up sensation from the nail bed on the dorsal side of the nail bed of the thumb, index finger, and the middle finger, and partly half of the ring finger, nail bed area. Relations of the lateral cord, medial cord, and posterior cord with that of the axillary artery. We are saying about the relationship of the cord of brachial plexus to the second part of the axillary artery. Second part of the axillary artery is an important landmark that is under cover of the pectoralis minor, and the lateral cord lies lateral to the second part of the axillary artery, medial cord lies medial to the axillary artery, posterior cord lies posterior to the posterior to the mid the posterior to the axillary artery second part. Okay. So if there is any type of hypertrophy of the pectoralis minor, then there is chance of compression to the brachial plexus structures. Also, if there is any axillary artery aneurysm, that may also cause compression or lesion to the brachial plexus cords. So brachial plexus cords are related to the second part of the axillary artery. Let's go to the brachial plexus. What nerve comes out of the root of brachial plexus? This is the long thoracic nerve. What is its root value? C5, C6, C7. So this nerve is behind the brachial plexus, behind the axillary vessels, and it starts from the posterior triangle of the neck, enters the axilla through the axillary inlet, okay, and this nerve passes over the serratus anterior. So this is the nerve this is not underneath the serratus anterior. This is the nerve that is passing over the serratus anterior. So this nerve is vulnerable to injury. Even it may be damaged during surgery like radical mastectomy or placement of the thoracostomy tube, or lymph node removal of the exita may damage the long thoracic nerve. That may lead to winged scapula or winging of the scapula. The medial border of the scapula will come out of the chest wall. We call it winged scapula or winging of the scapula. From the root, we're also getting another branch, the dorsal scapular nerve from the C5, and this nerve supplies the rhomboid major, rhomboid minor. It may also supply the levator scapulae. From the root C5, we are also getting contribution to the phrenic nerve. We know the phrenic nerve has root value C3, C4, C5. From the upper trunk or superior trunk, we have the suprascapular nerve that supplies the supraspinatus and infraspinatus. We're also getting nerve to the subclavius, supplies means innervates the subclavius muscle. We have the upper trunk or superior trunk, middle trunk, and the inferior trunk. Each trunk will have anterior division, posterior division. All posterior division will unite to form posterior cord that is present posterior to the second part of the axillary artery, okay, under cover of the pectoralis minor. So what are the branches of the posterior cord? We have 5 branches: superior subscapular artery, inferior subscapular artery, thoracodorsal artery. Superior subscapular artery and inferior subscapular artery, superior subscapular nerve and inferior subscapular nerve are the nerves which supplies the subscapularis. So these are nerves, not arteries. So superior subscapular, inferior subscapular supplies the or innervates the subscapularis muscle. Thoracodorsal nerve innervates the latissimus dorsi muscle. And we got these 3 branches of posterior cord. We have also 2 terminal branches. One is axillary nerve, and another is the radial nerve. Axillary nerve passes through the surgical. It is in relationship to that of the surgical neck of the humerus, passes through the quadrangular space along with the posterior circumflex humeral artery. An axillary nerve supplies or innervates 2 muscles. One is deltoid, another one is teres minor. So 2 muscles innervated by the axillary nerve. Axillary nerve is also provide cutaneous innervation over the lateral aspect of the shoulder contour over the deltoid muscle. We call the rank base area. So cutaneous innervation is provided by the axillary nerve over the deltoid muscle. Radial nerve goes down along the arm. It has a spiral course along the radial groove or spiral groove at the mid shaft of the humerus. Then it comes anterolaterally over the lateral aspect of the cubital fossa, and it gives cutaneous branches to the arm and the forearm, and it has a deep branch. That deep branch provide innervation to the supinator muscle and become the posterior interosseous nerve and innervates a lot of muscle like that of the abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus, extensor digitorum, extensor digiti minimi, extensor carpi ulnaris, okay, extensor indicis. The radial nerve supplies the brachioradialis and extensor carpi radialis longus and also enconius. And radial nerve also provide cutaneous innervation from the lateral 2/3 of the dorsum of the hand and also skin over the anatomical snub box. via the cutaneous branches. If we go to the medial cord, we'll get again 5 branches: the medial pectoral nerve, the medial cutaneous nerve of the arm, medial cutaneous nerve of the forearm, and we'll get the ulnar nerve and medial root of the median nerve. Okay, we'll go to the ulnar nerve. Then we'll follow the lateral cord. It has 3 branches: the lateral pectoral nerve, musculocutaneous nerve, and medial root of the median nerve. Musculocutaneous nerve innervates the coracobrachialis. It pierces the coracobrachialis. It innervates the biceps brachii and brachialis muscle. And at the elbow band, just below the elbow band, it becomes the lateral cutaneous nerve of the forearm, also called lateral antebrachial cutaneous nerve, that provide cutaneous innervation from the lateral aspect of the forearm up to the upper part of the anatomical snub box. Anatomical snub box is not covered by the musculocutaneous nerve. The cutaneous innervation from anatomical snub box is provided by the cutaneous branches of the radial nerve. Okay, we got the brachial plexus. Now we'll go to the next slide. Here, these are the brachial plexus, and we are seeing the sympathetic chain of ganglion, stellate ganglion, intermediate cervical sympathetic ganglion, and we know that sympathetic fiber are coming out of the lateral gray horn from T1 to L2. So any type of injury to the lower trunk of brachial plexus, like Klumpy's lesion, what will happen? There may be chance of Horner syndrome. In Klumpy's lesion, mostly the ulnar nerve is involved. We'll get the claw hand. Okay. Upper trunk may be damaged in some type of difficult delivery or certain type of fall. Difficult delivery may also cause lower trunk lesion like Klumpy's sign. Upper trunk lesion, we call it Arps-Lucien palsy, and people take the tip sign, so the arm is rotated medially adducted. Okay, so in that condition, we call it the tip sign. It is a feature of the Arps-Lucien paralysis. Okay, this is the musculocutaneous nerve. This is the median nerve, like a Y-shaped feature. It is coming from the lateral cord. This is coming from the medial cord. This is the median nerve, and this is the axillary nerve. It is in relationship to that of the surgical neck of the humerus. It goes to the quadrangular space along this area, along with the posterior circumflex humeral artery. Okay, so this is the intertubercular groove or sulcus here. It is related to the tendon of the long head of the biceps brachii. Here is the supraglenoid tubercle, long head of biceps brachii, infraglenoid tubercle for the origin of the long head of the triceps brachii. Axillary artery, it has 3 parts in relationship to that of the pectoralis minor, the proximal part from the outer border of the first rib to the medial border of the pectoralis minor, and this part has 1 branch, that is superior thoracic artery. Second part, that is under cover of the pectoralis minor, we have 2 branches. One is thoracoacromial artery, another one is lateral thoracic artery. Third part, from the lateral border of the pectoralis minor up to the inferior border of the teres major. From third part, we have 3 branches, like that of the subscapular artery, anterior circumflex humeral artery, posterior circumflex humeral artery. This is the axillary artery below the level of the lower border of teres major. Its name will be the brachial artery. Okay, that is multiple branches like the profunda brachii artery, some collateral branches. Okay, so and terminal branches like that of the radial artery, ulnar artery. branches of the brachial artery. Okay, what is wrist drop? Wrist drop is a condition when there is damage to like wrist drop. Person cannot extend the wrist area, so you'll got wrist drop. It is due to the lesion of the radial nerve. It is maybe due to lesion of the posterior interosseous nerve. There is the continuation of the deep branch of the radial nerve below the supinator muscle. So wrist drop may be due to trauma, okay, maybe fracture of the humerus at the mid shaft area, maybe fracture in the upper part of the forearm involving the posterior interosseous nerve. We may get wrist drop. Radial nerve we just discussed. It is coming out of the posterior cord of the brachial plexus. Root value is from C5, C6, C7, C8, and T1. Okay, it innervates the triceps muscle and coneus muscle, brachioradialis muscle, extensor carpi radialis longus muscle. Okay, radial nerve is related to the radial groove here. This is the radial nerve. Okay, it is passing along this, and this is the radial nerve. Okay, so it is passing along the radial groove of the humerus, and radial nerve is accompanied by the profunda brachii artery in the radial groove behind the midshaft of the humerus. Radial nerve damage here will lead to wrist drop, but usually triceps muscle is not paralyzed because triceps muscle get innervation from the radial nerve above the spiral groove. It also get innervation from the radial nerve above the spiral groove. It has multiple branches of the radial nerve innervates the triceps muscle. So it may not be totally paralyzed due to the innervation from the proximal to the site of lesion of the bone, and the radial nerve before that fracture line innervates the triceps heads. Branches of roots of brachial plexus we discussed. Branches of the upper trunk of brachial plexus we discussed. Okay, wrist drop and muscles innervated by the radial nerve. Okay, and it is going behind the mid shaft of the humerus along the radial groove. And posterior interosseous nerve is a continuation of the deep branch of the radial nerve. It begins from the lower border of the supinator muscle. Okay, so here is the root from the coming from the C5, C6, C7, C8, T1. We have two terms. One is prefixed when the C4 has contribution. We call it postfix when T2 has contribution, okay, to the brachial plexus. Okay, these roots are coming out in the posterior triangle between the scalene anterior and scalene posterior muscle. Okay, then it goes through the axillary opening here from just behind the clavicle. It goes out to the axilla. Okay. Okay. Here we are looking at the winged scapula or winging of the scapula. This is due to the paralysis of the serratus anterior muscle or due to damage to the long thoracic nerve. Long thoracic nerve passes over the serratus anterior. It is vulnerable to injury. Okay. So if the long thoracic is injured, we'll get this type of feature. In a very mild form of winged scapula is also possible due to damage to the pectoralis minor muscle, but that is much less wing in condition than that of the lesion to the long thoracic nerve and the paralysis of the serratus anterior. Okay. Location of the long thoracic nerve from the posterior triangle, it enters the axilla behind the clavicle, behind the axillary vessels and brachial plexus. It passes over the serratus anterior muscle. So it is not beneath the or underneath the serratus anterior. It is passing over the serratus anterior. That's why it is more vulnerable to injury. the long thoracic nerve, root value C5, C6, C7. Okay, we have to know the origin, insertion, nerve supply action of the flexor digitorum superficialis, flexor digitorum profundus, flexor pollicis longus, pronator quadratus. Pronator quadratus is present on the flexor aspect of the lower part of the forearm between the radius and ulna. Mode of insertion of flexor digitorum superficialis and flexor digitorum profundus. Flexor digitorum superficialis split on the palmar aspect of the first phalanx, and through this split, the long tendon of the flexor digitorum profundus goes to the distal phalanx of the fingers, index finger, middle finger, the ring finger, and the little finger. And the flexor digitorum profundus inserts to the base of the distal phalanx of the thumb. Flexor digitorum superficialis insert to the side of the middle phalanx of the thumb. So the flexor digitorum profundus is the muscle which can cause flexion of the distal interphalangeal joint, not the flexor digitorum superficialis, because it does not cross the distal interphalangeal joint. So flexion of the distal interphalangeal joint is carried by the flexor digitorum profundus. Okay. Nerve supply and action of the lumbricals, lateral to lumbrical lateral part. Okay, we have four lumbricals, lateral to lumbrical innervated by the median nerve, medial to lumbrical innervated by the ulnar nerve. Lumbrical muscles are inserting to the dorsal digital expansion. Okay, and they can flex the metacarpophalangeal joint, and they can extend the interphalangeal joints. Origin, insertion, nerve supply action of the opponent's pollicis brevis and the adductor pollicis. Opponent's pollicis innervated by the median nerve via the recurrent branch of median nerve. The adductor pollicis is innervated by the deep branch of the ulnar nerve. Muscles innervated by the posterior interosseous nerve. We discussed almost all the muscle on the back of the forearm is innervated by the posterior interosseous nerve. Okay, root value and course of the ulnar nerve. Ulnar nerve root value C8, T1. It may get contribution from C7 partly. Okay, so these are the muscle innervated by the ulnar nerve. Ulnar nerve innervates the hypothenar muscle. Median nerve innervates the thenar muscles. Okay, so we have to know that part. And ulnar nerve also innervates the dorsal interossei, all four dorsal interossei, and all three palmar interossei. Ulnar nerve innervates the medial two lumbricals. Ulnar nerve is also picking up sensation from the palmar aspect, 1.5 finger, and the medial half of the palm. It also pick up sensation from the dorsal aspect of 1.5 finger, that is the little finger, and half of the radial, half of the ring finger, and the medial 1/3 of the dorsal aspect of the hand. Okay, so you got the muscle innervated by the ulnar nerve. Origin, insertion, nerve supply, and action of the muscles causing supination. Supination is done by the biceps brachii, particularly it helps in flexion of the elbow in full supination. It is a strong supinator. Okay, it also causes flexion of the elbow joint, and flexion is good when the forearm is supinated. We have another muscle, supinator muscle, that is innervated by the deep branch of the radial nerve, okay, which becomes the posterior interosseous nerve at the lower border of the supinator. Pronation is done by pronator teres, innervated by the median nerve, and pronator quadratus innervated by the deep branch of the median nerve, that is the anterior interosseous nerve. Muscles of the hand innervated by the ulnar nerve we just discussed. Muscles taking origin from the lateral epicondyle, all the will get from lateral epicondyle the extensor muscles of the forearm, medial epicondyle common origin of the flexor muscles of the forearm. What nerve passes through the pointer teres? The median nerve. Flexor carpi ulnaris, the ulnar nerve. We may get cubital tunnel syndrome due to compression of the ulnar nerve in the flexor carpi ulnaris. Guyon canal for the passage of the ulnar nerve. Guyon canal is a canal between the pisiform bone and the hamate bone, hook of the hamate bone, and the piezohamate ligament. Okay, it contains the ulnar nerve. Carpal tunnel contains what nerve? The median nerve and 9 tendons. 4 tendon from flexor digitorum superficialis, 4 tendon from flexor digitorum profundus, 1 tendon from flexor pollicis longus. Radial group contains what nerve? The radial nerve. And what artery? Profunda brachii artery or deep artery of the arm. Okay. So quadrangular space, what nerve is passing through the quadrangular space? What is the content of quadrangular space? We have the axillary nerve and posterior circumflex femoral artery, that is a branch of the third part of the axillary artery. Triangular space, okay, that contain an artery, circumflex scapular artery. Though no specific nerve here. Triangular interval or lower triangular space, it contains the radial nerve and profunda brachii or deep artery of the arm. Carpal tunnel syndrome contained, we discussed, 9 tendon, 1 nerve, attachment of flexor retinaculum medially to the pisiform and the hamate laterally to the scaphoid and the trapezium. Cutaneous innervation of the hand, we just discussed that median nerve, ulnar nerve on the palmar aspect, on the dorsal aspect, radial nerve and the ulnar nerve. On the dorsal aspect, nail bed of the thumb, index finger and the middle finger, even part of the ring finger is covered by the median nerve. And that's all about the review of the exam 1 on the upper limb anatomy. If you have any question, please feel free to ask me. Please meet with me in my office during my office time. Okay, have a nice, wonderful and great day. Good luck.